Okay, in the interest of time, since I remember to start the recording, it only took two reminders. We're going to get started. So thanks so much, everyone, for joining our summer webinar, where we are going to have a number of our prize investigators share their studies and their work. So just to run through the agenda, we have Dr. Suni Kaiser talking about her SIP study. We have Dr. Chris Bonafide talking about IDECIDE Phase 1. Dr. Leonard talking about her eye care study. We have Dr. Bonafide again talking about emo, and then Dr. Khan talking about iPass Listen. So, Suni, you want to take us away?
Sure, thank you, and welcome again to everybody. Um, my name is Suni Kaiser. I'm based at UCSF in San Francisco. And today I'll be reviewing one of the prize-supported studies, which was known as the SIP study, but we just found out today it will be getting published soon under the title Implementing Respiratory Illness Care Pathways in General Hospitals, a Cluster Randomized Trial. So to give some background, I think everyone here is very familiar, but respiratory illnesses like asthma, pneumonia, and bronchiolitis are leading causes of childhood hospitalization. And most of these hospitalizations take place in general hospitals that predominantly focus on adult care. Um, there is a wealth of clinical pathway literature, largely from freestanding children's hospitals, and then a specific study from Seattle Children's where they tested simultaneous implementation of clinical pathways for multiple pediatric conditions. These studies from that center showed improved guideline adherence and patient outcomes. But this higher efficiency approach to pathway implementation hadn't been studied in general hospitals, which face unique barriers related to their focus on adult care. We can go to the next slide. So our objective with the study was to determine the effectiveness of a multi-condition pathway intervention for children hospitalized with asthma, pneumonia, or bronchiolitis in general hospitals. In terms of our methods, the design was a pragmatic cluster randomized trial. It spanned from July 2022 to June 2024, so 2 years. We randomized hospitals in one-to-one allocation to receive the intervention versus continue their usual practices in a waitlist control group. The core intervention was a bundle of clinical pathways focused on inpatient care of these conditions. And then the strategies we used to support implementation included monthly audit and feedback, electronic order sets with embedded reminders, and then iterative improvement cycles designed with the support of external facilitators or QI mentors. And our primary outcome was mean composite adherence across 7 total evidence-based practices. 2 or 3 applied for each condition, asthma, pneumonia, and bronchiolitis. And then our secondary outcomes included length of stay, need for ICU transfer, and then a combined outcome of either having a hospital readmission or a ED revisit within 30 days. And then our approach used a difference in differences analysis. So we compared changes in these outcomes from the baseline or pre-intervention period to the intervention period between the control and intervention groups. So this is our consort flow diagram. We assessed 66 hospitals for eligibility. As they understood the full scope and duration of the trial, some withdrew. But ultimately, we randomized 43 hospitals with roughly equal allocation to both arms. We did have several hospitals face significant challenges over this long trial and kind of coming out of the pandemic, with some pediatric units closing and just not having the resources to continue implementation. But ultimately, 37 hospitals completed the trial with over 11,000 admissions analyzed. In terms of our population characteristics, they were very similar for the intervention and control group. And all these kind of demographic variables were accounted for in our models in our final analysis. And then this is our sort of main study table, our main analysis. So for our primary outcome, this overall kind of composite adherence across the 7 evidence-based practices, and see in the intervention group, this adherence went up by 7.7%. In the control group, it went down by 3.7%. So in the difference in differences analysis, the intervention group had an overall benefit of about 10% adherence across, again, like a composite of these evidence-based practices. Each one is listed in the left side of this column, the ones for asthma, pneumonia, and bronchiolitis. So we focused on using standardized protocols for bronchodilator titration, using metered dose inhalers early in the hospitalization, and then for kids over 5, prescribing inhaled steroid controller meds at discharge. For pneumonia, our focus was really antibiotic stewardship, so using narrow spectrum antibiotics and avoiding macrolides. And then in bronchiolitis, avoiding unnecessary care, so no chest x-rays or albuterol. And then on the rightmost column in the difference in differences analysis, you'll see that for 3 of those 7, we had significant gains for the intervention versus control group as well. We can go to the next slide for patient outcomes. So we did find a significant benefit for children in the intervention hospitals in terms of risk of ICU transfer with a decrease in the odds ratio, with an odds ratio of 0.69, but no significant differences in length of stay or 30-day return for our intervention versus control arms. So, and then this figure shows by hospital the overall change. So the kind of navy blue dots on the left side are intervention hospitals, and you can see most in our adjusted models improvements in overall adherence, while the majority of control hospitals did not. And we can go to the next slide. So overall, in conclusion, we found this multi-condition pathway intervention was effective in this national sample of general hospitals, demonstrating significant improvements in adherence to evidence-based practices over this sustained period of 2 years. We did, as I mentioned a couple of times, have significant challenges with implementation, really aligned with overall kind of deprioritization of inpatient pediatric care in these settings, multiple unit closures, and just shifting of quality infrastructure support and other types of supports to other areas. And in terms of next steps, we did implement the intervention in the waitlist control hospitals after the trial period ended. So we're analyzing effects there as well as doing detailed analyses related to implementation fidelity. And I think I touched on some limitations next. So this study was participated in on a volunteer basis. We advertised through, different hospital network and hospitalist channels, but there may be selection bias related to those who felt they had the capacity to participate. But we did have a diverse population of hospitals geographically and in terms of size and other characteristics. And there was variability in implementation fidelity, especially around the things that required IT support, like order set modifications. And we, of course, studied this respiratory illness bundle, but we don't know the applicability to other kind of bundled conditions you might implement pathways for together. And then just some thank yous. This was a big, endeavor. We had a great kind of core team of people here at UCSF, but we worked really closely with the Society of Hospital Medicine, who oversaw all of our external facilitator coaching supports. And then, of course, our site leaders at all these hospitals that collected many, many years of data and oversaw implementation. And then we had great organizational partnerships, again, with Society of Hospital Medicine, but of course, PRIS and the AAP, and some other networks as well that we will be working with for dissemination. So thanks everybody for your attention. And I see some questions in the chat. I forget, Hadley, if we're doing those now or at the end.
Yeah, we can do those now. So do you just want to answer those couple questions and then other people can feel free to come off mute. We have just a minute for questions.
Sure. So I see the question about how outcomes were measured. They were retrospectively pulled using chart review, manual chart review. We were able to automate reports for several of the outcomes, like if an ICU transfer had occurred or length of stay. But for the quality measures, most of those had to be manually chart reviewed. Um, and then we did collect data on whether hospitals had pathways prior to the study. I would say roughly half had some kind of pathway or guideline, and then they used the ones we provided to adapt and align to sort of better highlight and remind people about these practices. Chris, I see your hand up.
Hey, Sudie, congrats on this about to be published and really great to see everything come together like this. Super exciting. Um, One question, and maybe I'll save the second one for later if we're short on time, but what do you think the mechanism was for the ICU transfer or the rapid response outcome? I was just trying to put that together. I couldn't piece it together.
Yeah, no, it we don't know, Chris. I mean, we didn't specifically target. None of the practices specifically would relate to a decrease in ICU transfer. We also looked at it and it was consistent across all three conditions because we thought maybe it was like condition specific. But it may be the fact that there's a lot of education around standardized respiratory assessment and frequency of assessment as part of the pathway. So there may have just been like earlier detection of clinical deterioration. But we don't know. I will say I didn't show sort of those data tables as carefully, but the control arm did start at a higher ICU rate too. So it's something to keep in mind that there may have been some unmeasured like confounding across the two arms.
Thanks.
Great, thank you. Dr. Baumgart, you're up next.
All right. Thank you, Hadley. Welcome, everybody. So glad that you came. I'm going to talk a little bit about iDecide, which is a partnership co-led by myself and Eric Kuhn. And iDecide is all about implementing clinically directed and empowered care with infant discharge evidence. And I'll translate what that means in a minute. So we can go to the next slide. This is our team. We just wanted to make sure everybody was recognized and acknowledged. Really incredible team bridging Seattle, CHOP, University of Utah, and of course, all of the sites that have participated thus far in phase one. So what's this all about? So iDecide is all about implementing as needed follow-up after bronchiolitis hospitalization, right? So there are kind of two paths to how we think about follow-up after hospitalization, whether it's for bronchiolitis or any other condition. The status quo at many of our hospitals is to say, go see your pediatrician in the next 2 to 3 days is kind of CHOP's de facto standard. Next 7 days is common. But we're almost always telling families that they should take their child back to see their pediatrician within a relatively short period of time, just to check and make sure that everything is going in the right direction. And there's a trial that Eric Kuhn led with Alan Schroeder and others prior to myself getting involved. And in that trial, what they did was they randomized babies with bronchiolitis to either get automatic follow-up, which was go see your pediatrician in the next 7 days, or as needed follow-up, which was, you know what, kid's got bronchiolitis, they're looking great right now. If all goes well at home, there's no need to rush back into your pediatrician's office. You can just go to your next well visit. But if anything arises that's concerning, please do give your pediatrician a call and set up an appointment if that's what you decide is appropriate. So that was the benefit trial. And what they found really was that there was that the automatic approach or the as needed approach was not inferior to the automatic approach with respect to parent anxiety was their primary outcome, but they also looked at some healthcare utilization outcomes like readmissions. This set the stage for what we're doing at IDECIDE. And what we also know, based on some other research that's been done more recently, is that as needed follow-up is underused. So even though we have the data from the benefit trial, we all know that simply publishing a paper of research results does not immediately mean that practice changes. So we're still using this only about 20% of the time, and about 2/3 of kids still actually follow up. So there's the prescribing, how often do we recommend it? And there's what actually happens. And I think it's pretty compelling that 2/3 of kids still follow up within 7 days of bronchiolitis hospitalization. That's a lot of visits that might be mostly unnecessary. So the goals of IDECIDE. So similar to the trial that Suni described, IDECIDE is a cluster randomized trial. So the goal of IDECIDE is to randomize not patients, but hospitals to one of actually three different arms. So we have what we call a moderate resource arm, a high resource arm, and then we have a control arm. So we have a group of hospitals that are not doing any implementation strategies. And we have an experiment going on between the moderate implementation strategy arm and the high resource arm. And then we're looking, of course, to increase prescribing of as needed follow-up as our primary outcome. And what we think will happen, this is our hypothesized graph. This is not anything based on actual data that we've seen thus far. What we think will happen is that we'll start around 20% because we had some data to suggest that that was probably where we were starting from other studies. And then what we thought would happen is in the moderate resource arm, which is really modeled after a traditional quality improvement approach to addressing a common problem in pediatric hospital medicine, what we thought we would see is that an increase in as needed follow-up that was a little bit less in the moderate resource arm than in the high resource arm. And then what we thought we would see after we do all this active implementation work is a drop back down in a sustainment phase that almost gets back down to baseline in the moderate resource arm, but is sustained more in the high resource arm. And the reason for that is because what makes the high resource arm high resource is that we add on to this sort of traditional QI approach that we have in the moderate resource arm. We add two more resource intensive strategies. So one is clinical decision support coaching. So hospitals are assigned a CDS coach, and that coach helps them first analyze what, if anything, exists in their EHR already for decision support for follow-up, and then helps those sites build new decision support in support of prescribing as needed follow-up. And the other is we have a problem-solving facilitation component where sites will meet on a regular basis with other sites and talk through any challenges they're having and how they might address those challenges. Yeah, so just to go in a tiny bit more detail about what we're calling sort of the moderate resource arm or the traditional QI approach, this includes education that reaches both families and staff, as well as some outreach to primary care. We have some audit and feedback happening related to follow-up prescribing. And then we have a toolkit. So in many QI collaboratives, right, there's a toolkit. Here are some ways you might put CDS into your system in support of as needed follow-up, but no actual external support to make that happen. So again, we modeled this after that kind of an approach. And then if we look at the high resource arm in the next slide, you'll see the components I just mentioned around the small group problem solving facilitation, and then the coaching that's happening related to decision support. So this is our design. So it's a 3-phase design. First phase is pre-randomization. So the idea there is we figure out how much as needed follow-up prescribing is happening at baseline. And then we move into randomization. So we've completed phase one, and I have a slide, I think, in a second about what we found in phase one. And then right now we're after randomization, but before the start of phase two, which will start in December, and we're working on standing up those implementation strategies. After phase two, we'll have a washout period where we stop all of these intensive strategies and then look and see what happens a season later in terms of if our as needed follow-up prescribing is sustained over time. So here's some results of what we've seen in phase one. So phase one is over. Really exciting. We had well over 200 people participate from 62 hospitals collecting data on about 2,500 kids. So I think that speaks to the power of the PRIS Network in doing big implementation trials. You heard from SUNYs, you'll hear about some more in a little bit, but really incredible effort, great participation from families. More than 600 responded to surveys. And what we found was kind of what we expected for phase one, which is that only about 20% are getting the recommendation to follow up as needed. And there was a ton of variation between hospitals, with some recommending it 0% of the time, literally, and some recommending it almost 80% of the time. And variation is great in implementation science, right? Because we can learn from the sites that are doing a great job already, and we can learn from the ones that are really having challenges even getting started. And we're also proud from an equity standpoint that we were able to recruit participants who speak more than 12 different languages. So excited about that. Thank you, Elisa, for the for the kind words in the chat. Cool. All right, that's it. Yeah, any questions for me before we move on to the next one? Yes. Great question in the chat. How is the follow-up recommendation ascertained? Yes. So the answer is we look in several different places, and then we have an algorithm that basically looks at, and I wish I had a slide of that, I don't, but so we look at the discharge summary, right? That's one source. And that source is potentially informative, right? Because that's the primary official communication between the hospital and the PCP. But then we also have the after visit summary or the discharge instructions that are given to families, right? So we look at those. And then we also, for the families that we're able to reach with the surveys, we also ask them what was recommended at the time of discharge. And we have basically a flow chart because sometimes one or more of those pieces of data is missing, right? So we have to kind of look and see what's there. For some sites, we even have access to the EHR and can see follow-up visits there. So I'm not going to get it right if I try to piece the algorithm together for you in words right now. But we do have one that helps guide these decisions when we're doing the analysis.
Thanks so much. Joanna.
Hello, everyone. A wonderful potpourri of studies. Today, I'm going to change gears to now talk about mental health boarding and preliminary effectiveness data coming out of our um, study of eye care, improving care, accelerating recovery and education. Next slide. I want to start by acknowledging our study team across several sites. And we'll begin by just giving you a quick orientation of what eye care looks like. Eye care is a digital health I'm going to skip over the background. I think everyone on this call is probably cool with justification for interventions to support youth who are experiencing mental health boarding. So we developed iCare, which is a digital intervention that consists of 7 modules. The topics are shown here. Each module has a brief animated video, as well as an accompanying workbook in which for adolescents can use without technology, since many hospitals do have technology limitations for this population, to try to teach them psychosocial skills that may give them a head start on recovery as they're waiting for discharge from their acute care hospital stay. Next slide. So in addition to introduction to what is mental health boarding, discussions of schedule making, safety planning, eye care covers psychoeducation, specifically understanding the cognitive or behavioral triangle, behavioral activation. Next slide. Relaxation skills and mindfulness. All right. So the overall goal of this study was to evaluate the preliminary effectiveness of eye care in two structurally diverse EDs, one freestanding children's hospital and one um, general hospital, looking specifically at changes in emotional distress, suicide risk, and suicide attempts, and also assessing potential mechanisms of change. This is a study funded by the National Institute of Mental Health, and studying mechanisms of change is one of their sort of key funding criteria. So we looked at coping skills, changes in coping skills, hope, readiness to change, and treatment expectancy following receipt of eye care. We specifically hypothesized that with exposure to eye care, adolescents would have improved coping skills and hope, really improvements across all of these mechanisms, and then subsequent decreases in these primary outcomes. Our focus population were teens 12 to 17 years of age who presented to the emergency department with suicidal ideation or attempt. We excluded those with developmental delays, such that they would be unable to complete our self-reported measures, aggression, or safety concerns. And as I mentioned, this was a preliminary study, so conducted at two different hospitals. And I have stepped wedge in quotes here because with two hospitals, there's not a lot of randomization that can happen, but we did try to emulate a stepped wedge design such that both hospitals underwent a period of baseline data collection, followed by a randomization around which hospital was going to start eye care first. We then followed outcomes up to 6 months following discharge. Um, This slide shows sort of the overall study design and the timeline. We started this in September of 2024, and at this point have two patients yet to complete their 6-month follow-up data. Site A, the lower volume general hospital, was randomized to start first, and you can see their total patient accrual on the blue boxes on the left. And then Site B, the freestanding children's hospital, followed them, and you can see their enrollment over each block here. And you can also see specifically at the children's hospital site that the summer block there from May to August of 2025 did have relatively lower enrollment consistent with seasonal variation in adolescent suicide presentations to the emergency department. So as a preliminary study, what's shown here is what's sort of one of our key outcomes, and that is our ability to recruit and retain our patient population over time. So we did fall a little bit short of our overall sample size target, which was just over 100, and ended up enrolling 89 patients throughout this study. The baseline measures were collected at the time of enrollment. T2 reflects measure collection at the end of the emergency department stay, and you can see that was where we had like the biggest drop off because it was so challenging to predict when teens were going to leave the ED and to have research coordinators there to facilitate completion of the surveys. T3 was 1 month after discharge from the emergency department stay, T4, 3 months, T5, 6 months. And our goal here was 75% retention, and I feel like we're not terribly far off. So I feel overall good about this, given that it is like a population, with substantial stress at a tough time of life. Next slide. And these results very much are preliminary because we're sort of at the point where we're figuring out the modeling strategy and using data that we downloaded a couple months ago. But I'll walk you through how to interpret these graphs. First of all, in red are the treatment as usual arm, and in sort of turquoise are the intervention or the eye care arm. The size of the circle reflects the number of participants who completed the measures. The width of the bars reflects the confidence intervals. And then you can sort of see the changes over time. So I will highlight right now, you can see like the T5 little circle here on the right is very small because this does not reflect all of the intervention group data. So take this all with a grain of salt. But what you can see, number one, a lot of overlap of the confidence intervals. So figuring out how to pitch this study for publication, welcome all feedback, suggestions in the chat, etc. Number two, you can see that over the 6-month period, sort of have a gradual increase or decrease in all of these measures. This graph is showing emotional distress. And if we go to the next graph, we see a sort of similar pattern evaluating suicide risk using the self-reported suicide risk measure called the Concise Health Risk Tracking. Here again, you can see in the eye care group between enrollment and discharge from the ED hospitalization, the suicide risk scores are almost flat. And then we do see sort of decreases up to the 6-month time period. And then next slide, our third outcome measure was assessed only post-discharge because all adolescents had suicidal ideation or attempt at the time of enrollment. And here you can see a decline from 3 months to 6 months, and almost meaningless data at this preliminary stage with the width of the confidence interval for the eye care group. So next slide. This is my first attempt at trying to summarize implications and next steps. And I think from anyone on this call, I would really love in the chat, or if we have time to share verbally, what you think of as key implications as next steps. But first, this is one of the first studies to look at mental health outcomes longitudinally following mental health boarding. I was really struck by how high those sort of post-discharge suicide risk scores remain, but that we do see gradual decreases over time up to 6 months. The largest signal of effect looks like, or potential effect of eye care appears to be at the sort of 1 month following boarding and the 3-month mark as well, with loss of that signal at 6 months, but again, very preliminary. And I hope, in terms of our recruitment, ability to recruit, to collect measures from this population, to keep them engaged up to 6 months, that this will all fold into justifying a future sort of larger scale prize study of this topic. So that's my last slide. And if we have a couple minutes, welcome comments, suggestions, next steps.
Feel free to put thoughts in the chat. In the interest of time, we can continue on. Back to Dr. Bronco.
All right, you ready for me, Heather? All right, let's go. All right, so I'm back. Hi, everyone. So I'm here to talk about emo. Many of you were involved in emo, but I'll still go through everything. For those who haven't, emo is a project that I've been involved in for about 8 years because it included two grants that were back to back. So I've been thinking about emo and pulse oximetry for a long time, and the overall very broad goal of emo is to de-implement continuous pulse ox in kids with bronchiolitis who are not requiring any supplemental oxygen or flow. So you can go to the next slide. So many of you know this background. So we have three sets of national guidelines that discourage the use of continuous pulse ox in bronchiolitis because it doesn't really have any benefits for kids who are not requiring supplemental oxygen that we've been able to prove out to date, and has a number of downsides. So for every hour of excess pulse oximetry that a kid with bronchiolitis gets, that generates about 7 alarms per hour, prolongs length of stay related to what we call treatment cascades in terms of, okay, if you see an alarm, you're more likely to go check on the patient. You're more likely to then decide they need to stay a little bit longer. You might also put them back on oxygen, things like that. So there are downstream things that happen beyond just the monitoring and the alarms themselves. And I think just a side note, I think we're talking a lot about implementation science here through these projects, and guidelines can be super helpful. So, it's great to have the existing evidence, but when you also have guidelines behind those, it can be super compelling to funders, right? Because a lot of what we have to do is convince someone else to pay for this work, and guidelines can be really helpful. Next slide. Yeah, so the broad objective of EMO, these are not the specific aims from the grant. These are sort of the translated to regular English version. So what we wanted to do was first use the implementation strategies, including education and audit and feedback, to reduce the use of continuous pulse ox in kids with bronchiolitis who are not on supplemental oxygen, and even more importantly, sustain that de-implementation over time after kind of the big main strategies are withdrawn. There are some notes that are the same as I decide here, with the focus on sustainment. And here we also are using clinical decision support. This was our initial version of CDS coaching, and you'll see EMO, some of the things that we learned from and then applied to I decide. We go to the next slide. So similar cluster randomized approach, of course, here in the PRIS network. And we took a very similar approach where we had about 50 hospitals participating in phase one. We looked at baseline. We then randomized. We did not have a concurrent control in this arm. And part of why we put one in, I decided, was because you can see trends over time, but without knowing what would have happened in the wild, it's tough to know how much of that effect you can attribute to your implementation strategies in a situation like this where you just have two active arms. And you'll see we had pretty, I think, compelling results. So we don't think it was all just what happened in the wild, but that question could theoretically still be asked. So we randomized to the two active arms, the sort of lower resource arm got educational outreach and audit and feedback, and the higher resource arm got those two things plus the CDS coaching. And then we withdrew the active de-implementation strategies and looked at what happened in terms of sustaining de-implementation over time. Yeah, so we used education, we used audit and feedback, and we had two forms of audit and feedback. And for those of you who were involved in EMO, you may remember we used the kind of traditional kind of group level audit and feedback where we sort of share this back with your department, share this in your division meeting, sort of aggregate data. But then we also did this thing called real-time inquiry. And real-time inquiry was when a data collector was sort of trying to figure out if a kid was monitored or not while they were off supplemental oxygen. That data collector, whether they were a hospitalist or a research assistant or a resident or a nurse, they were empowered to ask the clinician or any of the clinicians responsible for the care of that kid why the kid was monitored in a neutral, non-judgmental way. And then they documented those reasons there. And we thought of that as an interesting way to gather some data, but also a gentle nudge that could be performed by anyone on the team. Let's see, if you click, we should get, oh yeah, okay. So yeah, that paper that's pasted below is a paper that we wrote about what we learned from real-time inquiry. And then we also had CDS coaching, and I sort of described that in the IDECIDE realm too. I think a big difference here, and one of the things that we learned from EMO was that we knew going into EMO that the majority of the sites had some form of pre-existing CDS for pulse oximetry and bronchiolitis. And And we were maybe a little overconfident that, and the thinking there was, well, these hospitals still have an overuse problem. So if we throw more CDS coaching at them, they should still be able to make important changes in their CDS that will help them sustain. So that was an assumption that we made that ended up being not fully correct. But we did hard work to sort of prove that out, and I'll show you some data in a minute. We can go to the next slide. So this is what we hypothesized. So we hypothesized we would start around 50% overuse based on other data that we had, that we would drop pretty symmetrically between the two groups because we did not think that CDS was going to have a huge edge over audit and feedback and education. Audit and feedback is very powerful. And we've seen it work really well in the absence of any CDS. So we thought they would be pretty similar in phase 2. And then what we thought was that the rebound, so after we stopped doing the education and audit and feedback, the rebound between phases 2 and 3 would be much more upward to going back to the prior levels of overuse compared to the CDS coached sites, where we thought that would be more flat. So this was Suni talked earlier about diff and diff. This was a diff and diff, and focused on comparing the two arms between phase 3 and phase 1. That's what the dotted or dashed arrow is above. Next slide. Okay, results. So we had a diverse sample. We were able to do this in 38 sites. 35 were left at the end of phase 3. Not many general or community sites, which we were not thrilled about. And I think as we start thinking about next steps for EMO, that plays in. But we can go to the next slide. So how did the CDS coaching play out? So the table below was our philosophical approach, right? So we wanted to use what's called the 5 rights of CDS. So we're going to deliver the right information to the right people through the right channels, the right places in their workflow, in a format that makes sense. And I won't go through that for the sake of time, but that was our guide. And we had the coaches, they met virtually with site leads to first understand what they had existing, because again, remember 75% of these sites had some form of existing CDS, map workflows, and then design an approach that would hopefully give a leg up compared to what they already had. And this is what we found. So we started around 50%. So we were right about that part. We dropped pretty nicely in the two arms to about the same spot. So we were right about that. We were feeling really good in phase 2. We're like, okay, we're predicting what's going to happen. And then what you see between phase 2 and phase 3 is a symmetric, rebound, right? So we did not see what we were expecting, where we were expecting the blue line to be, and if you click Hadley, I think we can do a little picture in picture, yeah. We were expecting that blue line to be more sharply up, and it was not. So what we saw here, what we took away from this is that the decision support coaching did not improve sustainment between phases 2 and phase 3 as we had hypothesized. We were still happy with the reduction that we had. We were also happy that the rebound did not go back up to the prior levels, but we were a little bummed that the CDS did not help. We were also happy about this. So there were no adverse events. We had a really aggressive adverse event screening process here, and we did not see any adverse events that were attributable to prematurely stopping continuous pulse ox. We looked at code blue, we looked at rapid response, we looked at revisits to the emergency department. So this was a very safe approach. Then we looked, and we're probably short on time, so I'm going to go quick here. But what you see here are broken out by coaching and whether or not there was pre-existing CDS. And the takeaway here is that if you look at the blue and the green lines, those were sites that had no pre-existing CDS. And even in those, we did not see an effective coaching. So sadly, coaching for this problem in this context was not helpful. And I think, Hadley, why don't we go to the EMO 3.0 slide, and we can certainly talk in the Q&A or afterwards, about the rationale. We have a lot of theories as to why we saw those results that probably don't have time for at this moment, but would love to talk more about it. So where we are now, so we're obviously writing the paper and all that, but I think we've had some reflections over the past few weeks, and I think what we want to do is we want to think about, does it make sense to do more emo or not? So one of our reflections, and I think SUNY and Corey McDaniel and others have been inspirational in this regard, is that we felt really good. We affected 35 hospitals, but those are 35 out of the thousands of hospitals that care for children every year. And so we're starting to think about what would dissemination look like? What would dissemination look like that's focused on general and community sites as an exclusive focus? And how might we engage others in that process? And also, how might we get funding to do that? I think we would have a good shot at getting NIH and or PCORI funding to do an EMO 3.0 that again was really focused on how can we spread this innovation of de-implementation to general and community sites. So would love to talk more to folks who might be interested in that. I think we have like a REDCap link that maybe Kim can throw in the chat for anybody who might be interested in exploring. Oh, thanks, Kanita. Who might be exploring the idea of de-implementing pulse ox in your site if you're a community or a general site. So I'll leave it at that. Thank you, Hadley. Oh,
Thanks,
quick
Chris.
question there. Yeah, I can answer that in the chat. Yeah, so we can keep
Great.
going. Sound.
A great team. Look at all the emo babies. We love it. Okay. Lisa.
Thanks everyone for having me. I will tell you a little bit about our study called the Patient and Family Centered IPASS LISTEN study. LISTEN stands for Language, Inclusion, Safety, and Equity and Teamwork for Equity now. Next slide. So this is a study that is ongoing and just about wrapping up the RCT portion of data collection. It's a hybrid type 1 study, which means it focuses both on effectiveness, does it work, and implementation, is it working as intended, and how do you make it actually work in real life settings? And it's a cluster stepwise randomized control trial at 8 hospitals that's comparing usual care and 2 different strategies for family-centered rounds. The population is over 14,000 patients with a goal of having half who speak English and half who speak a language other than English. We are measuring outcomes, which I'll tell you about in a moment, through a combination of surveys of families and patients and staff, as well as observations of rounds and other communication touch points, and then doing an intensive systematic safety surveillance process, which includes reviewing charts, family safety reporting, reviewing hospital incident reports, and talking to staff to understand errors and adverse events of all of these arms. And our outcomes are looking at patient safety, hospital experience, communication, discrimination, and disparities in all of these outcomes. On the next slide. What are our 2 round strategies that we are looking at for family-centered rounds? The first is called Patient and Family-Centered IPASS, or PFC IPASS, which essentially means we encourage active participation of patients, families, and nurses on family-centered rounds at the bedside. We use health literacy principles. So instead of saying afebrile, tachycardic, we'll say had a fever, heart rates were high, things like that. We use structured communication, namely the IPASS structure, which I'll show later for presentations. And then we do a teach back at the end of round. So asking the family to share in their own words the main takeaways or what they'll be looking out for or what the discharge criteria are, for instance. And then we supplement the verbal communication with a written summary of rounds for families. So that's round strategy 1. Next slide. The evidence for rounds strategy 1 I'll go to in a minute, but essentially the way you use the IPASS structure on rounds is you start with illness severity and introductions, where you start with saying who the team members are if they're new, and you ask the family if they think the patient is better, worse, or the same, and ask them what concerns they have that they want to talk about on rounds. So sort of agenda setting. The patient summary is then the presenter presenting high level, the one-liner, and if they want to do SOAP, they can do SOAP. And then you go through the action items, situation awareness. So if this happens, this is what we'll look out for. And then there's the synthesis by receiver. Next slide. We found in prior studies, a 7-center effectiveness study and a 21-center implementation study that are both completed, which we published in BMJ and in Pediatrics, that there were improvements in patient safety, reductions in medical errors, improvements in family communication and experience, and rounds did not take any longer, and teaching of trainees did not decrease when we put this PFC IPASS program into place. We also did an implementation study where we used a bunch of intervention implementation strategies, including coaching sites in the intervention with families, nurses, and physicians, and found that this was successful. We had good intervention adherence and improvements in safety climate and harms, particularly in those who adhered more and had more admissions and better nursing engagement. Next slide. However, we did find that when we did secondary analysis of data from these two studies, we found that there were disparities in patients who spoke languages other than English, where hospitalized children whose patients had limited comfort with English were over twice as likely to have adverse events. And we also found that patients who spoke English were 2 to 5 times higher, had higher odds of speaking up when something didn't seem right, questioning providers, and asking questions compared to those who spoke languages other than English. And we published those both in JAMA Pediatrics. Next slide. So we came up with this second rounding strategy called PFC IPASS Plus. And so it's essentially all of the components of traditional PFC IPASS, but we added a couple additional components thinking through things with an equity lens. One was we made that written summary of rounds multilingual. And the way we did that was we created an electronic REDCap interfaced process so that we could have summaries of rounds in 14 languages. And then we did training on cultural humility and trauma-informed care and on working with interpreters and best practices for that. Next slide. So back to IPASS Listen, our study aims were to compare PFC IPASS Plus, and usual care, which is just rounding however you round, and see the impact on outcomes. And we hypothesized that the PFC Plus arm would have greater improvements than the PFC arm for patients using languages other than English, but would actually also improve outcomes for all patients, all patients as a balancing measure. And we also thought that both of these rounding strategies would narrow disparities in these outcomes, but that PFC Plus would have higher reductions in disparities. And then our implementation aim was really to understand contextual factors that contributed to fidelity and implementation so that we could disseminate this in the future. Next slide. This is just a study timeline, which shows that we are almost at the end of, actually we are at the end of data collection, and now we're in the sustainment period where we're measuring data. And a big shout out to PRIS, which was really instrumental in helping us think through and change our study design in a way that had better scientific validity. So that was something that PRIS was really valuable in. And then next slide. An important principle of our study was really co-producing the study and the intervention with families, with nurses, and with trainees, and in our implementation strategies as well, and doing this in a multilingual fashion. Next slide. And we had a approach for multilingual access in which we had multilingual family advisors, REDCap, budgeting for translation and cultural adaptation, and we had our patient our study and intervention materials and electronic materials in 12 languages other than English. Next slide. And this includes pictures of our family flyers, our electronic round summary, our family orientation videos, and then a study summary video that we showed to staff. Next slide. You can forward again. And so where we are, we just completed primary data collection. We have enrolled nearly 15,000 patients, including nearly 7,000 who speak a language other than English and over 8,000 who speak English. We've got about 8,000 surveys from patients and families, and we are doing our intensive process of reviewing charts and other other sources for errors and adverse events. We've also done interviews with families, including 12 in languages other than English, and with staff, and we've observed over about 1,000 rounds observations. Next slide, just wrapping up. We're now entering the sustainment phase, where we'll be doing some light observations and light touch implementation and focus groups. Next slide. And we've had some secondary scholarship that I just wanted to quickly shout out the authors of this too on the next slide. One around how families feel unheard in hospitals, listening neglect. Another around disparities during family-centered rounds for families who use languages other than English, particularly families who use languages other than English or Spanish. Next slide. And then we've had other papers about the development and evaluation of our multilingual caregiver electronic round summary, and then evaluating post-editing AI translations versus professional translations. And I think the next slide is just saying that we're wrapping up. There are lots of abstracts and publications around different topics. So it's a good example of just how you can have a bunch of data and find opportunities if you're interested in a particular study question to take on some aspect of it and run with it. And so we have a lot of people involved in different parts of this, which has been really exciting. Next slide. And we are finishing our physician reviews for errors and adverse events, cleaning data, doing data analysis, and then working on some of these ancillary studies. So stay tuned for what we find out. We haven't analyzed yet, but there's a lot of data to do. And on the next slide, I just want to give a big shout out to our very large study team and PRIS for its support both on methodology, but also in comprising our data safety monitoring board and helping us even put together the application. Wouldn't have gotten this without their support. So thank you so much. I'm happy to take any questions.
Great. Well, thank you all so much. Really appreciate you all joining us on this Summer Wednesday, and we will be in touch with a future webinar. And thanks to all of our presenters. Have a great day, everyone.